Good afternoon, everybody. My name is Saoirse Reid, and I'm the nurse consultant, learning disabilities and autism for University Hospitals Plymouth. We have a main site, Derived Hospital, and other sites, but we mainly work on one site, which I know is very different to other liaison services, but at the moment we focus on the main hospital. We're also an 8 to 4 service, and we are a 7-day service. At the moment we're doing 6, but we had some recruitment issues last year, now fully recruited into, so we will be running a 7-day service very, very soon. An interesting discussion there around what happens after 8 till 4. And we have discussed at one point looking at an on-call service for the region, so whether or not that's something we might want to approach, which would mean that one of the liaison nurses across the Cornwall and Devon would probably have to do an on-call week, maybe once every 10 weeks. So again, it's about how do we get that up and running and agreed, etc. So this is currently our team position. It's took 12 years to get here. Originally, the service started, as with most of the trusts, with one acute liaison nurse who was a band 7 at the time, full time, and then was joined by a second from Cornwall, because we provide services to Devon and Cornwall, with it being a major hospital. And that's initially was those 2 nurses trying to do everything. So over the years, I joined the team as one nurse retired and went down to a 2-day week. And then we started building from there, because it is quite a large population it serves. So I sit directly under the Deputy Chief Nurse, which is brilliant. It's great to be in that position, because anything that's even day to day, we can escalate quite quickly. We can also be advocated for our population groups, but also the teams work at quite directorate level. So we've got really good support as well from our chief nurse and our board. And so I know different liaison teams work differently, but I think that's, in my opinion, the best place to sit in terms of getting the support and leadership that the liaison team needs when walking across sometimes lots of different services and patches. We also have a medical lead for learning disability, so we've had a medical lead for about 5 years. Again, it took a considerable amount of discussion to get that medical lead. They do a 2.5-day week, so not loads, and mainly help us with subject judgment reviews, but will also every now and again consult in very complex cases, especially around palliative care, because the other hat is, well, the main hat is palliative care lead in the trust. We also have a manager, service manager, band 8A, a clinical lead, so that's the day-to-day management of the team and coordination of the work. We have 3 band 6s. We now have a band 5 that we've grown ourselves through the Marjan Aspire programme. So that's my second hat. So I'm actually the lead programme, co-lead programme for the Aspire Learning Disability Nursing Training Programme at Marjan University. So we've been able to grow our own, and that's been really useful in progression planning. I got into that because I was really passionate about making sure there was more learning disability nurses on patch, especially local, and really make sure that we have enough people in the workforce for when some of us will retire in a few years. So we also have team assistants, and a lot of places don't have these, and they're absolutely vital, because there's lots of our liaison work and role that is administrative, and that actually a band 2 or 3, depending on your organisation what they are, can take a lot of that off, which means the nurses can go out and work more clinically. Next slide, please. So my background, so I know a lot of acute care services don't have consultant nurses. I think in terms of Devon and Cornwall, I'm the only one across patch. And I think it really does help give assurance up to board around the compliance that it needs in terms of making reasonable adjustments, and any other papers like this one comes out, the recommendations, benchmarking it, are we doing it, can we do things differently, and then making those changes or supporting others to make those changes. Again, so I'm consulting. I was line managing last year and consulting and doing some clinical work. However, because we've made those changes and having the Band A, I can step away from line management and really focus on not only supporting the liaison team, but I support other medical teams, surgical teams in terms of how they might improve their own services, or I might go in and consult expertly on very specific or challenging cases, especially those that might end up in court. So they've got that extra expert advice, and I own and review the learning disability and autism policy, and I'm happy to share that. And again, it's all ages, so just so you're aware, we stopped doing the adult and paediatric separately, and we're an all-age service. So again, we look after support people with learning disabilities, and we support autistic adults without learning disabilities. Next slide, please. So the actual nursing process, so as mentioned earlier, alerts are very, very key. So we have 4 main alerts that we use. We have one for learning disability, LD is an attribute, that's what they will see on the screen, but when they hover over it, it will say learning disability. This person has a learning disability, or is alerted, not learning disability diagnosis, alerted as having a learning disability, please do this. We also have an alert for HP hospital passport. So again, staff member can go over that with a mouse and it'll say, does the person have a hospital passport, or we'll mark it if they do, and it'll say, please read the hospital passport. So that's important. I'm going to talk about that a bit later, so I won't go into it too much now. We also have an AS attribute for if the person's autistic, and that's 3. So we have somebody who self-reports, so doesn't want a diagnosis, but they're self-reporting as autistic, they will get alerted. We also have people waiting for assessment, so we'll alert them as that, and then we'll have people that have had assessments, and we will see all of those individuals, so we don't exclude on the basis of having a diagnosis or not. All new learning disability patients will be seen within 24 hours, so we'll come in, the team will come in that morning, and they will have a virtual patient list for learning disability and one for people who are autistic, and then they will review, they'll know the people that are new, and they will make plans who they will visit that day. So we are going to Epic. It's all very new, and we've took the opportunity where we were very paper based, so we would be having put stickers and notes, which is our care plan around, you know, checking if the person needs reasonable adjustments, have they got a passport, would we advise adults, things like that. So we would have that as part of our nursing process. So we've now put that into a care plan I'm happy to share, and part of that care plan will identify things like the social backgrounds. Have they got pets at home? Are they caring for somebody at home that we might need to know about? Are they under safeguarding? And then part of our key job, after gathering maybe some of that information that in an emergency admission is not always gathered, we will then look at the reasonable adjustments, and we actually have a reasonable adjustment risk assessment tool that's digital we can share, that we use, that will help identify the level of the person's need, which is low, medium or high, but also specific individual reasonable adjustments for that person. The staff will see that they have that reasonable adjustment form completed, because they will be alerted as RA, so that was the final alert, and they'll be able to hover over that, or say, see the reasonable adjustment risk assessment tool and recommendations, and they'll be able to go in and see reasonable adjustments needed around communication, extra support that they might need, if they've got any sensory issues, if they need a side room. So all of those reasonable adjustments will be on that form. And the key thing is just making sure that staff are alerted to it and read it once we complete it. So in terms of our autistic populations, what we tend to do is, because they're usually a lot more able to advocate for themselves, so we have introduced a pack for them, and it has different types of hospital passports that they might want to use. It also has a self-assessment for themselves to say, well, okay, I'm on this ward in this environment, what do I need? And they can sit with a nurse, not necessarily us or somebody or the partner who's with them, and they will complete that and then inform the nurse of it. The only time we really get involved after that point is if the case becomes specifically complex, the person becomes non-compliant, then we might get involved a bit more and do some direct support with that individual, because the key thing is that they are compliant so they can get well and go home. The same with paediatrics. We often find that they're well advocated for on the paediatric ward. So again, we just make sure that they have the resources. We have paediatric link practitioners who are great, and they'll make sure that they're all up to date. And we only get involved if there's, you know, a complex need or a family or requesting support to maybe speak to a consultant, that type of thing. And then we evaluate the care and the feedback. So we send out our own, they have family and friends, but we also send out a plain English version to those who are autistic who's just been in hospital, and we also send out an easy read version, and then we review them annually and come up with some ideas about how we can improve our services. Next slide, please. Thinking about time. So the outpatients, so we have a dedicated role at the moment to look at outpatients. So they will look at advanced bookings, ring them up, see if they need support. They'll also follow up on our 2-week waits. So we get notified about our 2-week waits now. So they're not waiting longer than 2 weeks, especially if they need a GA or some sort of sedation to have an MRI scan. So we pick them up early, and they'll also follow up on DNAs. When we've had it as a whole team doing it, this work seems to get lost, especially in winter, in the busy months. So this is why we have a dedicated role for it. Next slide, please. So what else? Well, there's lots of other things the team do. So we lead on our engagement group, so it's Derriford User Group and Derriford Autism Group. And again, there is a real concentration on improving services. So they've campaigned for communication boxes, books, changing places, facilities, and this is after doing mystery shops. So they've actually done like quite a lot of work. So if anybody wants any support or information about setting up an engagement group, do let me know. We lead on our monthly GA clinic. So this is so people can be planned to come in and have procedures that they don't particularly like under sedation or GA. We do training for the trust. We also support our leader reviewers. We complete our subject judgment reviews. We do our link to link with our practitioners or our champions, maybe you call them in other areas, and we have 162 in the trust. So if anybody wants to know how to get that off the ground and support with that, let me know, because we use a reasonable adjustment heat map that they do every year, and we produce that to board, and wards or departments can be gold, or they can be red, which is not very good. It's usually picked up. Why is that ward red? And it just means that they've been doing 2 or 4 or more reasonable adjustments a year in their department to keep on top of things. So it's not a certificate, it's an ongoing thing that we do. So we provide teaching to local universities, and we also actually support our colleagues who are neurodivergent. Sometimes I might get a call from a manager to say our administration team, some people are neurodiverse, can you support us with that and the environment that they work with? Next slide, please. So that's some of the thanks to the team. So we do get a lot of thanks, and I make a point of making sure this is in our annual report to the board to show the appreciation and the impact that the team has, and I think that's really important. We also use patient stories when we report into our quarterly. We report on safeguarding. It's really important for liaison teams to show their impact, and if that's true, thank you to patient stories. That is the best way to go. Next slide, please. So because we've got a larger team, and because I can drive quality improvement now in my position, when I was managing the team and a consultant nurse, I could only get half of this done, but I'm in a much better position now to drive quality improvement, not only from our team, but across services, which is brilliant. So the Wait and Well project, so we're reducing waiting times for people on certain specialty lists for waiting longer. So we've now put together a triage bookings form for the bookings team to escalate people that might fall into that long wait. We're also doing a priority pathway for 2-week waits, because it's very difficult to arrange off-the-cuff GA with the people that you need in that room to support that individual within 2 weeks. So we're looking for a pathway, so our team aren't having to do it all the time, and that other teams on that pathway, like oncology. We're going to talk about the hospital passport in a minute. We're going to do the Oliver McGowan in-house training team, but I'll leave the rest for you to have a look at. But I think that's key. It's not just about seeing patients, it's about how can we make things better across the trust in certain areas, etc. Next slide. So we now have a hospital passport app. It is based on the Gloucester original readapted hospital passport, the paper version, so the traffic light version. Next slide, please. What we found is that lots of people were losing them, not bringing them in, and the information wasn't ready. So we did this with Hereford User Group, and we co-produced the actual app. So it has been done with the service users. What they wanted is for it to look the same. They didn't want to have to relearn or get familiar again with another hospital passport they've been using for 10 years. And the staff, when we got staff feedback, basically said the same. Next slide, please. So it went live in 2022 and you can get it from your Play stores. Next slide, please. And yeah, you can skip the next two slides. It's just what it looks like. You can have a look at that. The pain one is in there, so them soft signs. We did have to go through governance for this, but it's a patient-owned document, so it is not a medical record, and that is how we got it over the line. That's the key thing. Next slide, please. So yeah, where we are now. So there is a link on this slide where you can go on and get all the resources for the Hospital Passport app, easy read, how to sign up. It's free for everybody. So in your area, people can use it. You just won't have access to the staff hub. But I'd still encourage people to use it because they can now print from it. So they can set up a PDF file or get support from somebody to do that and email it. So if they are in hospital and have got the app, they can just arrange and email it to the admin if they're in ED or on a ward. So just so you're aware, people can use it now. And I know I'm out of time, so I'm not going to go through any more. I'll be in trouble. Thank you very much.